Hello and welcome to this program brought to you by the Vizient Hospital Improvement and Innovation Network, also known as the Vizient HIN. Today is the second webcast of this year's Community Knowledge Network Education Series. In this program, we will continue our examination of a critical issue in healthcare today, and that is diagnostic errors. We'll take a look at it from all angles: patient safety science, what's being done in practices, as well as how patients can work with clinicians to improve it. The National Academies of Sciences, Engineering, and Medicine estimates that every one of us will likely experience a misdiagnosis in our lifetimes. We'll hear about the research that estimates that approximately 12 million adults are adversely affected by misdiagnosis every year. Today we have three experts to share their perspective on research, practice, and the patient experience. We will discuss what can and is being done to improve diagnostic error. I'm Dr. Robert Dean, Senior Vice President of Performance Management at Vizient, and your moderator for today's program. And now let's meet our special guest. First we have with us Helen Haskell, who's the president of the not-for-profit group Mothers Against Medical Error. Helen, welcome, and briefly tell us about your background and your contribution to the show, please.
Well, Robert, thank you. I'm glad to be here. I am first and foremost a mother. I'm the mother of a child who died from misdiagnosis many years ago. I've been a patient safety advocate ever since then. I've worked with a number of different groups and in a number of different fields. And I am also chair of the Patient Engagement Committee of the Society to Improve Diagnosis in Medicine.
Thank you. We appreciate all the work you've done since your loss.
Thank you.
We also have with us Dr. Dennis Torretti from Geisinger Health System. Dennis, welcome. Please tell us a little bit about your background and your contributions to the show.
Thank you, Robert. I'm a rheumatologist by training, former chairman of medicine, currently serving as the Associate Chief Medical Officer at the Geisinger Medical Center in Danville, Pennsylvania. Today, what I would like to do is highlight some of the preliminary steps that we've taken within the Geisinger system to enhance the diagnostic process, identify and prevent diagnostic errors. Clinical diagnosis is a foundation of medicine, and the challenge posed by diagnostic error is formidable without a clearly defined roadmap to approach it. Nonetheless, it's important for each organization, each health system, to take some of these initial steps to learn more about diagnostic errors, share information, and learn if we are to make progress in this area. It's an essential element, and I believe it's important that we proceed.
Thank you, Dennis. We look forward to hearing about the work you're doing at Geisinger. And last but not least, we have with us Dr. Hardeep Singh. Dr. Hardeep Singh is from the Michael E. DeBakey VA Medical Center and the Baylor College of Medicine in Houston. Welcome, and please tell us about your background and your work in this area.
Thanks, Robert. I'm a general internist, and my passion for improving diagnosis really started when I was in private practice in rural East Texas. And what I wanted to do was to sort of change the way we practice medicine and change policy and change the system around me. But as a single practitioner, I was not able to do so. So what I started to pursue was looking at the science. How do we use evidence to improve practice? How do we translate that research into improvements and policy changes? And so what I did was I was able to get some grants from the federal government, and that's thank you to the Agency for Healthcare Research and Quality and Department of Veterans Affairs for supporting this research. And what I've been able to do is to build a multidisciplinary team that brings together concepts from several disciplines working together to reduce diagnostic error.
Great, thank you. We look forward to hearing about that research. Before we begin, let's review our learning objectives. After viewing this program, you'll be able to describe how diagnostic errors contribute to patient harm, identify key considerations in implementing a program to address diagnostic error at your organization, and discuss ways that patients can be effectively engaged to help prevent diagnostic error and delay. To illustrate the critical nature of today's program, Diagnostic Error, let's hear from Helen Haskell and her experience with her son. Helen?
Well, I said at the beginning that I was the mother of a child who died from misdiagnosis. My son was Lewis Blackman. That's a name that some of you may have heard. I just want to I want to tell you a little bit about what happened to my son, and but I want to start out before that by telling you something about who he was. Louis was the top scoring student in our metropolitan area of Columbia, South Carolina. He was a soccer player, he was a math champion, he was an award-winning writer for the newspaper. And he was one of those people who just had sort of an intuitive sense for other people's feelings. He could take size of a situation very quickly and work to change it. We thought, of course parents aren't objective, but we thought he was on a different plane really from other people, other children, and that he was someone who would really do great things in the world. And my point in telling you this is just that medical tragedies affect us all, not just the families and patients and clinicians who are involved in them. They really tear a hole in our society. It's something that we all have to work to stop. So here's what happened to my son. Shortly after his 15th birthday, his father and I took him to a teaching hospital for a procedure to correct a birth defect that he had called pectus excavatum, which is where the breastbone just doesn't grow straight. It's really a cosmetic defect, and it was cosmetic surgery. We took him there because we'd seen an article in our local newspaper about this safe, new, minimally invasive surgery that was very easy to recover from. What we didn't realize was that that wasn't quite what we would experience. We didn't realize how difficult and complicated the pain regimen for this surgery was. And I don't think the people who were taking care of him realized that either. So after his surgery, Louis was on heavy doses of epidural hydromorphone, an opiate, plus 6-hourly doses of the NSAID ketorolac. People were very focused on the opiate, the control drug that was in his epidural, and nobody gave much thought to the NSAID that he was receiving by IV. Then on the third day after surgery, which was a Sunday, early in the morning, right after a ketorolac shot, he was suddenly stricken by this excruciating pain in the area of his stomach. And the nurses and residents who were taking care of him on the weekend dismissed it as an ileus, as constipation caused by the narcotics that he was also taking by epidural. The long and short of it was that 30 hours later, after hours of deteriorating vital signs, Louis died. He hadn't seen an attending for 2 days. He'd had no complete blood count. Even after 24 hours of no urine output and 4 hours of no detectable blood pressure at all. The young nurses and residents who were taking care of him really had no appreciation of how severe his condition was. They were astonished when he went into cardiac arrest and died. The next morning, an autopsy showed a giant duodenal ulcer of a type that we later learned was typically associated with NSAID overdose. And he had lost 2.8 liters of blood and gastric secretions into his peritoneal cavity, about 3/4 of the blood in a child his size. So the question we had, and the question that anyone would have, is what on earth happened? Well, this was really, as we learned, a classic failure to rescue, which is one of the most deadly forms of misdiagnosis in the hospital. It was a culmination of multiple factors. There were system factors, there was fragmented care, inappropriate supervision of residents, there were cognitive factors, premature closure, confirmation bias, and there were behavioral factors, lack of teamwork, lack of attention to the patient and family and what they were saying, and lack of a culture of safety overall. But I think one of the things that really haunts me is that intervention at any one of these points could have changed the picture completely. A system is made up of individuals, and until individuals have the insight and the courage to act and to try to change it, the system won't change. I know we all feel powerless. We as patients felt powerless, but we're not. As individuals, we can do a lot.
Helen, thank you for sharing that impactful story with us, and again, our deepest sympathies. This is an unfortunate example of a diagnostic error and why it's important to further explore this topic in today's discussion. For another introduction to diagnostic error, we visited the Agency for Healthcare Research and Quality. They are the federal agency that supports research in areas that can improve healthcare. Let's hear what they have to say about diagnostic error.
Diagnostic error is a relatively new area for us. Research shows that 10% of deaths can be attributable to a diagnostic error, and a lot of medical malpractice claims are also associated with diagnostic error. So this is a really important problem that we want to try and do something about.
There kind of, I think, was an assumption that we were better in healthcare than we actually are. And so for something as fundamental as diagnosis, it's really important to understand how well do you do. There's a misconception that the heart of the problem is that somebody did something wrong. What's often the case with patient safety problems, including diagnostic error, is that the system itself is flawed in some way. Getting a diagnosis is not a single event like some of us have thought of it. It actually sort of sets the stage for many different things and many different steps that follow. It's hard to get the right treatment if you've got the wrong diagnosis to begin with.
One of the important things we feel that we need to do to help improve diagnoses and prevent diagnostic error is to come up with a measure of diagnostic error. We want to look at clinician factors. We want to look at organizational factors that prevent the clinician from coming up with a good diagnosis. Communication between physicians, physician, nurse, etc. And we also want to make sure that IT is doing all that it can to facilitate the flow of information. It's sometimes hard to know when diagnostic errors have occurred, and one of the things we're really interested in doing is setting up a surveillance system so we can know when they've occurred. We want to very carefully track what we're doing and look at the impact of that on patient care. We think we can do better.
One of the things I'm hopeful about and we can expect for the future is more understanding, a wider understanding about this problem of diagnostic errors and how it fits within the broader context of patient safety in general.
There's no one finding that's going to solve this for us completely, but continued research will come up with ideas that we can put into practice and implement, and we'll continue to chip away at this process and hopefully improve diagnosis continually in the future.
A great overview of the multiple variables that go into diagnostic error, the integrated nature that they have, as well as some of the things that we can do to decrease the impact and the occurrence of diagnostic error. Helen, your thoughts?
Well, I think they do a really good job of pointing out how fundamental diagnosis is, and yet how complicated it is. It's really the same thing that I was saying earlier. They're using different words to say the same thing. This is both a system error and an individual error. There are a number of components that all played a role in Lewis's death and in many other errors and other diagnostic harm.
The problem with diagnostic error is that it provides a significant challenge in measurement. It's a complex process and a complex undertaking. It's much more difficult to measure and assess diagnostic error than it is to assess central line associated bloodstream infections, catheter associated UTIs, and other quality metrics that we have in place. But nonetheless, this really shouldn't keep us from taking steps to address the problem, the issues, and move ahead in our efforts to identify and prevent diagnostic error.
Yeah, I agree with Dennis. You can't really improve if you cannot measure safety, and you can't measure if you cannot define the problem at hand. And so what we've done in our work is call these missed opportunities in diagnosis as a first step to promote understanding. So we've looked at lots of medical records to see what could be something different that could have been done for diagnostic process. And based on at least 3 studies that we've done, we made an estimate, and we estimated 12 million adults are going to be affected by diagnostic error every year. And about half of these are potentially harmful. So this is a pretty big deal.
Yeah, those numbers are staggering. I mean, literally that's tens of thousands a day that are occurring and impacting patients, as well as every one of us at one point in our lifetime will be subject to misdiagnosis. In terms of definition, the IOM defines preventable harm as the failure to establish an accurate and timely explanation of the patient's health problems or communicate that explanation to the patient. Hardeep, how do you take this definition and operationalize it into your work?
Yeah, so this is a tough one. What we have done is we do realize there's lots of judgment calls involved. Diagnosis is not always black and white. There's a lot of uncertainty in diagnosis that needs to be taken into account. So when we do case analysis, we generally use 3 criteria that we found useful in defining it as a diagnostic error. The first is we look for unequivocal evidence of a missed opportunity to make a correct or timely diagnosis. So really, we'll look for, could something different have been done in this case in order to call it a diagnostic error? The second is we try to frame the missed opportunity within the context of an evolving diagnostic process. So we know that things change with diagnosis, conditions progress, symptoms progress. Initially, there's a lot of undifferentiated symptoms. It takes time sometimes to make the diagnosis. So we account for uncertainty and account for the fact that there are a lot of gray zones. And the third criteria is the opportunity could be missed by anybody, not just the provider. This is not just about what's in a clinician's head. It's about the care team, it's about the system, as well as the patient. So the opportunity could be missed by anybody.
So how does this approach to diagnosis help you in your work?
Yeah, really. So, it really helps us focus on what we can change. So we've found a lot of system factors as well as cognitive factors associated with these missed opportunities. And so if you look at the orange circle in the figure, we'll look at that circle of preventable harm from diagnosis, which is where we focus, is area B, where there's things that you could do differently in terms of missed opportunities. And sometimes there's not a clear evidence that there was a missed opportunity. But we want to go for preventing harm in cases when there is, because of a delayed diagnosis, there's either delayed treatment or wrong treatment or wrong test or delayed testing. So we'll look for missed opportunities in helping us figuring out where the problem is and where to go focus in preventing harm.
And what does the research say about the risk in diagnostic error?
So we talk about several, so we've looked at the entire diagnostic process, and we've looked at things like the clinician interview, where you take a history, you do an exam, you order tests, the tests come back, you got to follow them up, you have to interpret the test. We've looked at how people gather information, synthesize information, communicate that information to the patient. And then in terms of finding out about your question on sort of what is this research telling us, we are finding common conditions being missed. So we're finding things like infections, cardiovascular conditions, cancers being missed. So it's not just the rare conditions that are being missed, but it's also the common conditions that get missed. So that's sort of what we're finding in our work. We also have looked at lots of medical records, and we find differential diagnosis is not being documented. So 80% of the diagnostic errors in one of the studies that we did not have any evidence of differential diagnosis documented in the medical record. So, even though when we may take the history and the exam and find those red flags, we may not act upon them. And we might miss test results and not do a differential diagnosis. So all of these things is what we are finding in some of the work that we're doing.
Well, another point that I want to bring in is the lack of patient family involvement and patient family input can really make a difference in terms of misdiagnosis.
Yeah. And we found that as well in our work, yep.
Dennis, Geisinger started to take a more systemic approach to diagnostic error. How did you begin this process?
In 2014, there were some disparate efforts ongoing. There were a few individuals with an interest in diagnostic error, but our Chief Transformation Officer and Chief Quality Officer convened a group, the Diagnostic Exploration Team, that consisted of clinical leadership as well as our Chief Medical Informatics Officer. And the discussions were broad-ranging. It involved topics such as how can we use health IT, decision support, how do we begin to address cognitive bias, what areas in terms of medical legal liability claims should we be considering, what areas should we focus on. In any event, out of those discussions, there developed a diagnostic error work group. And this diagnostic error work group was charged to target diagnostic errors, identify clinical champions, prioritize areas of opportunity, and incrementally build a program that would begin to address the issue, the problem of diagnostic errors. We had broad clinical representation. In addition, we had representation from a patient who happened to be an employee and offered considerable input into the process. The diagnostic error work group defined several goals for the system. The first being to establish a system and culture that values diagnostic excellence, understands the diagnostic process, and learns from its errors. Second concept was simply to develop strategies, innovative strategies to identify and reduce diagnostic errors, delays, and near misses. Third was to develop a mechanism for both individual and organizational feedback so that all could learn as part of the process. The fourth item was that we wanted to enhance education and training of all providers in the diagnostic process. And lastly, we wanted to more effectively utilize health information technology in the diagnostic process to support the effort.
I'm sure that this work is of interest to other delivery systems out there. What organizational elements or structure have you used in developing these processes?
There are some key elements that we thought were essential for this work to move ahead, to proceed. We felt that we had these elements present. Perhaps we're not perfect in these areas, but there's progress in these areas. One is a culture of safety, in which we've made considerable progress. Secondly was engagement of the Division of Quality and Safety in this process, and they've been actively engaged. We needed active leadership support from our Chief Quality Officer as well as our Chief Medical Officer. And we needed to have sufficient, very capable health IT capabilities in order to move this ahead. In order to accomplish these goals, however, it was felt that we needed more than a work group to accomplish the goals that were defined. As a result, it was proposed that we develop the Committee to Improve Clinical Diagnosis with a more formal structure in place. We proposed this committee with a charter and a reporting structure. It's a subcommittee of the System Peer Review Committee, and the Committee to Improve Clinical Diagnosis reports directly to the Clinical Leadership Council. The Clinical Leadership Council is the body that's responsible for oversight of quality, all quality efforts across our system. And this Committee to Improve Clinical Diagnosis has broad representation of clinical staff from all disciplines, representatives from risk and patient safety, as well as representatives from our medical informatics staff.
Excellent. What were some of the first steps that the committee took?
The committee's early in its work at this point in time, but we've made progress in several areas. We've developed a registry for reporting and characterizing diagnostic errors. That's been an important first step. We've established a hotline pilot in the Department of Medicine that allows the reporting of diagnostic errors. we've tried to focus on 3 patient populations that appear to be at risk or have diagnostic areas as part of the issue. The first is we're reviewing all serious and sentinel events within the system to ask the question, is there or was there a diagnostic error present that contributed to this event? Second area is the area of emergency department returns within 48 hours and patients who were admitted. Was there a diagnostic error or miss in that first ED visit that prompted the return? And the third area is a review of our medical legal liability claims, asking the question, was there a diagnostic error that contributed to this claim?
Are there other steps that Geisinger is considering in addition to this work?
Yes, there are. One of the more important steps that we've taken was to invite Dr. Singh to visit our organization last year. We thought it might be helpful for Dr. Singh to meet with our staff and begin to discuss approaches to the problem of diagnostic errors. How can we best approach this issue? As a result of that issue and subsequent discussions, it was felt that we should collaborate in developing and further refining this approach. And we have a proposal in place that's moving ahead in terms of this collaborative effort. So not only do we anticipate moving ahead the items that we've discussed already, but we hope to be able to address a number of other patient populations that are at risk for diagnostic error in the future. This includes patients who are transferred to a higher level of care, failure to rescue, failure to diagnose, patients who are admitted within 10 days of a primary care visit, as well as unexpected mortality within our system. There are a few areas we hope to be able to address.
Hardeep, from your standpoint, why is this collaboration significant?
This is really exciting for researchers like us because Geisinger Health System is one of the systems that has so many attributes of a learning health systems, and I think we've heard about those just in the last few minutes. And it really gives us an opportunity to translate some of our work into practice. So we've talked about this for a long time, but this is the first time there's going to be a large-scale collaboration between researchers in diagnostic safety as well as health system leaders who are interested in this area. So we can measure, understand, and then start reducing diagnostic error. This is actually the first ever learning lab for doing that, and we're going to call it the Safer DX Learning Lab. And this is from a grant that is funded very generously from Gordon and Betty Moore Foundation, and will tell us a lot more about how to do this in the future.
So go a little deeper for us. How will this learning lab advance your research?
So, one question I often get asked is, how do we do this stuff, and what do you do next? What does an organization do to improve diagnostic safety and reduce diagnostic errors? So, we've, through our research, have developed frameworks and strategies to do that. So this is a great opportunity to translate that framework. We call it the Safer DX measurement framework. And what it helps us do is to get us closer to the safe patient care that we all are interested in. We know that measurement of diagnostic error is now ready for quality improvement. It's ready for learning, it's learning and for research purposes. So we want to generate some of this knowledge and then translate that into feedback for the organization, for the clinicians within the organizations. Now, we're not building measures for public reporting. We're not building measures for performance measurement or for any penalties. What we are doing is we're generating evidence to inform tools, strategies, knowledge that can be used by other health systems who are looking to that question. Where do I start in approaching diagnostic error, and what do I do next?
Dennis, you had mentioned that at Geisinger one of the priorities was leveraging information technology, other technologies. What does that look like? How are you doing that?
Well, we're fortunate that we have an electronic health record that links our entire system, and it's created for us a large database. And this system has been in place since 1996. More recently, we've implemented an IT system referred to as a unified data architecture, which allows us to mine and probe this database as well as other databases in great detail. And so having this clinical data warehouse is of considerable value to us, and it's allowed us to do some interesting things. There are several areas in which we've been able to close the loop. For example, we've identified, using this database, abdominal aortic aneurysms that were detected incidentally in which there wasn't follow-up. An appropriate follow-up was obtained as a result. We're using the same process to probe radiology reports to identify pulmonary nodules that require additional follow-up. An exciting area is the use of this database in real time to identify patients at risk for sepsis and septic shock. And there's a work group utilizing this information currently that we think will be exciting and helpful in developing tools to identify patients at risk. We think there are opportunities to develop additional clinical decision support. I would also mention the fact that the Geisinger portal that allows patients to have access to the laboratory data as well as patient notes, open notes, allows us to engage patients in this process. A few examples of attempts to engage patients in the diagnostic process.
Excellent.
If I could just interject here, I mean, I think that's one of the most important things. It's one of the things that we as patient advocates have advocated for many years. The patient access to the medical records, patient ability to annotate and provide input into the medical records so that the patient gains an understanding, the family gains an understanding they can share with their family, and the clinician can gain a better understanding from the patient's input. It just provides for more clarification of diagnosis.
Hardeep, from your standpoint, how can information technology be used to improve diagnostic error?
So, I would say information technology has a lot of potential, but we're still fairly early in our goals of using health IT to improve healthcare and improve diagnosis. So I would say there's at least 3 phases involved for us to get us there. So the first phase of this has to be, we've got to have safe technology. So we can't be having technology which is broken or clunky electronic records or electronic records that don't communicate with lab or the lab interface is broken, for instance. So we got to have no glitches. We got to have good technology, well designed. The second phase of information technology and how it can be used to improve diagnosis is we got to use that technology safely. So we could have the best electronic health records in the world and we may not be able to use them correctly or safely. We could also bombard clinicians with a lot of alerts and reminders that would be useless, and therefore we would not be using this technology very well. And then the third phase is, I think, what Dennis was trying to get to, is how do we use technology? How do we leverage health IT to identify patients who might be falling through the cracks or who might be at risk for delayed, wrong, or incorrect diagnosis before they are harmed? How do we do that? And in our work, we found a socio-technical approach being the most useful. And what I mean by that is not just looking at the technical aspects of the software or the user interface, but also thinking through several of the other dimensions. There are 8 actually in this model that we have proposed. We got to think through all the 8 dimensions. So some of them will include things like workflow, organizational issues. All of those issues have to be addressed in order to move technology forward in improving diagnosis.
So in the video and in our discussion, we've addressed the systems component of diagnostic error. We also had brought up earlier the cognitive component. Can we speak a little bit about that and its role in diagnostic error, Dennis?
It's cognitive issues, cognitive biases are clearly one of the important areas in diagnostic areas. In our work, initially we've identified several areas that were problematic. Anchoring, Confirmation bias, premature closure appeared to be an important element in the genesis of errors that we've identified thus far. We've tried to work through some of these issues through educational programs, presentations at Grand Rounds, presentations at Morbidity and Mortality Conference. We've also developed an internal webpage looking at diagnostic quality, where there are a number of references for individuals relating to cognitive reasoning, heuristics, and bias.
I think this is really one of the most interesting and maybe even one of the most promising areas of diagnostic research. One of the things that I see in the many patient stories that I've heard is preconceptions about people, unconscious bias. So there's bias against the mentally ill. When they present with physical symptoms, people tend to assume it might be psychological. Bias against the elderly, assuming they have problems that they don't necessarily have just because of their age. And then the tendency when you can't find a diagnosis to jump to the conclusion that it is a psychiatric issue. I have seen much patient harm caused by the psychiatric diagnosis. And by psychiatric, that includes things as mild as anxiety, which is often in a hospital setting. Patients who have real problems may be dismissed as anxious. And then there's what happened to my son, the healthy patient bias, the assumption that a young, healthy person really can't have anything serious wrong with them.
And I shared with you yesterday in my practice how I had underestimated how sick a patient was and really had problems with that. So I know it exists. Hardeep, your thoughts here?
Yeah, you know, this is clearly a complex area. We just don't know enough about how clinicians think, and there's hundreds of biases to address. So one of the areas that we've looked at is overconfidence. So we did a study in which we gave 4 cases to clinicians. The physicians were general medicine docs. There were 2 relatively easy cases and there were 2 relatively hard cases. Both of them were in vignette fashion. And what we tried to do was to illustrate what their accuracy and their confidence in that accuracy was. And what we found was in the easy cases, about 60% of them got it right, and their confidence was about 7 out of 10. And in the harder cases, the accuracy really fell to 6%, but their confidence didn't change much. And so what that was telling us was the clinicians were fairly confident, even in the midst of a lot of uncertainty and a lot of difficulty of that situation, of that case, that they thought that they were right. And they were fairly confident, and they really didn't seek for help. We even asked them, do you want to seek any help before you go further? And we didn't really find that to be true. So we really think both uncertainty and overconfidence are areas that must be addressed as we go forward.
Interesting, significant findings. There's been a lot of movement on different tools used in diagnostic errors. The AHRQ website has one on improving diagnostic error and a wealth of other knowledge assets that they've compiled that will be helpful on this and other topics. Let's see what AHRQ has to say about the use of diagnostic tools.
So one of the important functions that the agency has is to share the information that we develop. And one of the important ways we do that is through tools and guides.
We have a toolkit for physician offices in their lab testing process and making sure that that process is as efficient as possible and the information gets to the right place at the right times.
We have several dozen of these available for use that are focused on different problems. We actually have one on diagnostic error already. So as we develop more research and gain better understanding, we can broaden the set of tools that we have available to address different diagnostic error challenges.
These tools can be anything from a checklist to a guide as to how to communicate better. We can provide practical products to clinicians out in the field so they can reap the benefits of the research that we do. We certainly don't want research to be published in a journal and then filed away someplace. We want to make sure that it's used to the benefit of American people.
So a great example of various tools that we can use in diagnostic error. Helen, from a patient standpoint, tools that can be leveraged?
Well, you know, there are a number of tools out there. One that we like is the Society to Improve Diagnosis in Medicine. Their patient toolkit's available on their website, which is improveddiagnosis.org. And it's a pretty comprehensive toolkit that helps people learn to prepare, do research, think about the questions to ask, and follow through. What do you do after a diagnosis? So our thought is that patients need to be prepared. Patients need to do their own research. That is one ability that we now have with the internet. And patients have the time and the motivation and the understanding of their symptoms to really do thorough research in a way that their clinicians might not have the time to do. So they can do that research, organize their thoughts, ask specific questions like what else could it be, and tell their provider, and I think this is really important, to what you think it is, what you're most concerned about. And then people need to know how to follow up on test results and changing symptoms.
And what can clinicians do to help patients in this regard?
I think they can simply mirror what I just said for patients. They need to elicit those responses from patients. What do you think it is? Tell them what to do if things change. Explain the concept of differential diagnosis. Explain your reasoning so that the patient can say, well, that's not quite what I meant. You misunderstood me there. So that together you can reach the diagnosis.
And we saw in the ARC video a simple tool that could be available in a physician's office that just reminds patients to be good historians, take good records, keep good records, those kind of things. Dennis, at Geisinger, you're just starting this process, a systematic approach. How are you engaging patients in developing that process?
Well, Robert, as I mentioned earlier, we've added a patient to our committee, which has been of considerable assistance in the design of this effort. I believe that our open notes and the My Geisinger portal are important elements in engaging patients in the diagnostic process, but there's much more that we can do. There's considerable opportunity to do more to engage patients in the process, and we look forward to doing that in the future.
Hardeep, is there one area in terms of patient engagement that you would like to highlight?
Yeah, one area that I would say is totally ready is missed test results. So this is when there's lack of follow-up of abnormal test results. So despite good electronic communication, despite getting better at making systems for communication, we're still finding missed test results in about 8% of patients. So that's 8% of abnormal labs or 8% of abnormal imaging that doesn't get followed up. And that's where patients really could play a strong role. There's often this misconception that no news is good news from the doctor, and we need to get rid of that myth. No news is not good news. And so really patients can be engaged in following up the results.
And Hardeep, I think tests and technology are really critical. Patient involvement in that area is really critical now because there's so many things that can go wrong. Tests and technology are so important now in diagnosis and treatment in every aspect of medicine. But tests can not just be not followed up on, they can be not ordered. The wrong test can be ordered. Tests can be misinterpreted. Patients need to be able to sort of follow up on those things and say, well, this doesn't seem right. And because clinicians are spending more and more time on tests, and they're spending less time talking to the patient, taking patient histories, doing careful examinations. So patients need to be proactive.
Yeah, and we find that very commonly in our work. Clinicians are getting over-reliant on tests and technology and not listening to patients enough.
And then assignment of responsibility to follow up on tests. If we look at the data and the transition of care guidelines, 40% of patients that are discharged from an acute setting have pending diagnostics, and 10% of those will be critical results. So somebody has to follow up on those. A patient needs to be aware that they're hanging out there and follow up as well. So a lot of good stuff here. Before we go any further, let's get you involved. We're ready for you to join the conversation and to chat with us online. Simply type in your question in the box of the lower right of your computer screen and click Submit. We have a few questions already from the audience, so let's get to those. Dr. Torretti, I think this one's for you. What lessons have we learned from your work thus far? Are there any successes that you can point to at this early stage?
The work is early in its development, but I think there are a number of lessons that we've learned thus far. Number one, it's important to focus one's efforts. One can't difficult to take on the entire question of errors across the system in one fell swoop. It's important to focus on specific areas and work towards success in those individual areas. First item. Secondly, be patient in the process. It takes time. This work has evolved over a 1 to 2 year period, and it's ongoing. Progress is being made, but it does take time and effort. Thirdly, it's important to have the appropriate people engaged, individuals who are passionate about this area, as well as clinically credible individuals. It's important to have risk and patient safety staff involved, as well as the medical informatics people. But those are some of the areas that I think have been important for us. In terms of successes, there's one area that was of note. As we began looking at a number of areas, we identified an issue with epidural abscess, delays in recognition. And one area that was more of a system issue was the delay in getting MRIs in the emergency department. There was a significant delay in getting the studies done in a timely fashion. We've worked with our radiology department, and this has now been corrected significantly. We've made progress in that area. It's one small example of a system-like issue that has been addressed.
That's a great example because there's many efforts to decrease diagnostic scanning for low back pain in the ED, but here, if you're suspicious that it may be an epidural abscess, get that scan right away. Exactly. Can I follow up? What's medical staff acceptance been of the process? Is it a process that people are aware of? Is there resistance? Has there been leadership buy-in to this?
We feel there has been leadership buy-in to the process. We've had considerable support from leadership in the efforts.
The medical staff leadership?
Medical staff leadership. Okay. Our chief medical officer has supported this effort, as has our chief quality officer. Many of the individuals who serve on the committee or have been part of the work group in the past have been or are clinical leaders in the organization, and that's been helpful in moving the process ahead. We're still in the process of rolling the process out to the entire medical staff, but it's thus far it's been accepted well.
Great. This looks like a Dr. Singh question. Any lessons from your work on follow-up test results?
Yeah, I mean, there's plenty to talk about, but one thing I kind of want to highlight is, we looked at test results that were being sent to two people. For instance, let's say I'm the primary care doc and I send the patient to a specialist and the specialist order the test. Now, the computer knows who the PCP or the primary care doc is. The computer will also send the result to the specialist because the specialist ordered the test. So if it's abnormal, the specialist will receive the test. If it's abnormal, the primary care doctor will also receive the test, right as a flag on the computer, so we can make sure we take action on it. And what we found was when the result is sent to two people, the risk of loss of follow-up went higher. In fact, it was double. And that was because we distributed the responsibility of follow-up between two people. So I was thinking, oh, the specialist is going to take follow-up, and the specialist thinking, oh, the primary care doctor is obviously following the patient. They will take follow-up. And so diffusion of responsibility is a huge issue for test result follow-up. And we actually changed our local as well as national policy on who was responsible for test result follow-up. So I would encourage all institutions to look at your policies to see, have you even outlined who's responsible for follow-up at your own institution?
And what's your recommendation in terms of follow-up?
Yeah, our recommendation was ordering clinician
Right.
has to be
Okay.
responsible for follow-up unless they delegate that responsibility in writing to somebody else.
Excellent.
So we wanted to make sure that we assign it to one person to do
And
that.
you would encourage that actually be in policy and procedure for our organizations?
I would say, most organizations I've talked to have agreed with this initial recommendation that we came up with. We did this in the VA. There's other institutions now adopting similar types of policies. It's hard to sort of delegate and responsibility to somebody else if you're not the ordering clinician.
Right.
Each situation might be different, and that's why it's an individual decision at an organizational level. But I think that's a huge consideration. It's not an easy question to answer. It
Yeah.
sounds simple, but it's not easy to address.
Right. Helen, do you think that things have changed over the years since Lewis's passing?
That's a hard question. I've been doing this for a long time, and yes, of course, things change. Whether they've changed for the better, I think a lot of things have. We now have rapid response to help with failure to rescue, which we actually didn't have in many institutions at the time that Lewis died. We have greater awareness of the problems and more attention to the patient, greater patient-family engagement in hospitals, which is really critical when a patient is having an unexpected problem. But I think on the downside, I think there are other changes that might offset some of that. We have a much faster pace now. We have a higher volume of medicine. Sometimes we have people with less training and experience than we might have had before, with less time to interact with the patient. So there are pluses and minuses, and I think we need to just work on getting everything into the plus column.
But as we spoke yesterday, we were saying that we thought that person and family engagement has really advanced, especially in the last few years. And we were at a CMS conference, our Vizient team, a couple of weeks ago, and CMS really made a point that they wanted to see improvements in healthcare that are patient-driven. So I think the recognition of the patient role in care has really improved in this time.
I think so too. I think that's really one of the great advances in patient safety that we have.
Yeah, and I would say, the increasing, so all the rules and regulations could be for us or sometimes could work against us. So some clinicians might think that electronic health records have brought in a lot of new burden and pressure and takes them away from patients. But at the same time, we're trying to make technology to make things go smoother. So there could be risks and balances of new rules and regulations. But I think I've seen this trend over the last few years that national organizations, including CMS, now there's a lot of interest from the National Quality Forum in trying to put in place some kinds of measurements for diagnosis. Everybody's on board. We have a committee right now that I'm a part of that National Quality Forum has put together to look into the diagnostic process. How do we try to measure this? How do we try to improve it? And they're also taking a very patient-centered approach in making some of these suggestions on what to do next. What are the concepts to be put forward? So I think it's great that the national agencies are getting engaged and taking more of a patient-centered approach in thinking about what policies or rules or regulations that we need to sort of put out there.
So we've talked about the difficulty of measurement. We've talked about using this in a non-punitive way, but I have to ask the question that I think others are probably thinking about too. As a former chief medical officer, do you see the point where we'll use measurement of diagnostic errors either in credentialing or re-credentialing and privileging for medical staff?
I can say the basic science of measurement of diagnostic error just isn't very well developed yet. And I think this is where the partnership that we're putting in place with Geisinger Health System is a big, useful start because we want to push the science forward. We are trying to do measurements for quality improvement, learning, and research. We are trying to stay away from everything else in terms of penalties or punitive stuff, and even to the extent of credentialing or some kind of pay for performance. We're trying to stay away from that. The approach is going to be just for learning only. I don't know how it's going to look like in another 10 years, but certainly I would say at this point in time, the science is fairly undeveloped.
And at Geisinger, it has been tied into the peer review process. The committee is a subcommittee of the peer review committee, correct?
That's correct. That's correct. It allows us to review individual cases within the structure of the committee. We've broken up the committee into two. The committee meetings have two components. The first is a general discussion. The second component relates to the peer review process when individual cases are reviewed and discussed.
Okay.
Well, you know, my perspective on that is that diagnosis is something you learn. So if somebody is doing a poor job at diagnosis, I think that's one of the things in medicine that would be more amenable to training and learning than some other issues might be. So I don't see that as punitive. I see it as more remedial.
Okay. Another question from the audience. Do any of the facilities of the speakers have a patient brochure given at admission that encourages patients to speak up when something doesn't seem right? Do you know of any of the programs, or do you have anything like that at Geisinger?
We have a program that is referred to as the Patient First program, that in which we have a physician, a senior physician, on call, and if there is a concern by a patient, a family, a nurse, or anyone caring for a patient, involved in a patient care, that they feel things aren't moving in the right direction or their concerns, they can call Patient First, the Patient First physician on call to address the issue.
And they're given something that notifies them of
I don't
that?
know if that's in place at this point in time,
Okay.
Robert.
Anything else that you're aware of, either one of you?
Patient brochures, well, we have in South Carolina, we have the Lewis-Blackman Act, where people are required to be given in writing information about how to get help in case of an emergency. It's not quite the same thing, but it's similar. Yes, and I think there's even the Joint Commission Speak Up program. There are things like that around. The problem is you get so many things on admission that people don't always see them until they get home.
We've got about 30, 45 seconds here left, but Dr. Torretti, what steps would you suggest organizations take to begin to address some of the cognitive issues, biases that contribute to diagnostic error?
I think as one identifies diagnostic errors and cases are discussed at morbidity and mortality conferences, for example, it's important that this be part of an educational effort, and the specific biases, the cognitive issues that are part of that case be openly discussed, and efforts made to understand how this impacts the diagnostic process negatively. I think we have a lot to do in the educational realm in this regard. There's been a lot of work, literature on critical thinking, type 1 and type 2 thinking, and biases that result. And we're just beginning to get this information out to students, trainees, and staff in general. So an ongoing continued education effort is going to be important. It needs to be reinforced over and over again.
And I would add, I think what we're all kind of getting to is learning from feedback, because we often don't know what's the diagnosis we get right and what's we get wrong. And so we need to have better systems of learning about, what are we doing in practice and getting feedback. And
I guess the final comment that I would make is that diagnosis really does need to be a team sport if it's complicated. And one of the things we haven't mentioned in this discussion is the role of nurses. But nurses, patients, physicians, and not just nurse practitioners, but bedside nurses, everybody should be vigilant and providing input on these things.
Well, you do have the last word, because we are at the end. We have a couple of questions that we did not get to, and we will email the responses out for that. So thank you for those who have submitted questions. Helen, Dennis, Hardeep, thank you very much for sharing your expertise and your thoughts on this critical issue. It's been a very informative show, and it's been a privilege to have all of you on the program. Thank you. I also want to thank Dr. Sharon Arnold and Dr. Jeffrey Brady from the Agency of Healthcare Research and Quality for their comments earlier. And thank you for taking the time to join us today. Thanks also to the Vizient HIN for their ongoing support of this series. If you registered in advance, the program evaluation will be emailed to you. Please take a moment to complete it. Please mark your calendars for the next web broadcast in this series on Wednesday, September 27th on the topic of choosing wisely. And now from Vizient, I'm Dr. Robert Dean. Thank you for watching today.